Well, all of us who do coronary interventions have seen that patients who come to us with very large size vessels or there is a mismatch between the two major branches, main vessel and the major side branch, and the patient requires a bifurcation stenting. The challenge is how to select the size of stent, and once you select the size of stent according to the main branch, and the stent has to go onto the main vessel, the same stent is not possible to expand up to the diameter of the main vessel. So there is always a challenge to the interventional cardiologist. We conventionally have stents which, for example, Synergy 3.5 can go up to a diameter of 5.25. But sometimes we have got a vessel larger than even 5.25. Number two, we do not know what happens to the polymer and what happens to the stent once you dilate this stent of 3.5 to 5.25. It looks, angiographically looks very fine. As you can see in this example, the left main is very large and Synergy was put. The overall result after bifurcation stenting looks to be respectable. But yeah, when you look at I was in these kind of patients. Now this is a pullback from the LED to the left main. You saw the stent was well opposed into the LED, but once you see into the left main, as you see here, as the IVUS is coming towards again the run, LED stent is well opposed, and the circumflex joins it now, and you see the stent is very much malopposed in the left main. So although angiographically you are very satisfied, but if you look at the IVUS, this problem is not too often. So therefore, the interventional cardiologist has voiced the need for a better stent, which is large enough for proximal vessel than what is available with the current generation of the drug-eluting stents. A stent which in such cases can provide a high radial strength and axial strength when it is brought to the diameter of the main vessel. It should have a large overexpansion range. It should optimize the scaffolding at the larger diameters, and it should be able to, we are able to place it very accurately. I am unable to move it precisely. Now, when you look at the new stent which has been introduced by Boston Scientific called Megatron, and I'm sure all of the people sitting in this room have used this stent, has certain peculiar features, and these features are different from the Synergy which is available to us 10 peak stent. So the number of peaks in the Synergy are 10, whereas there are 12 peaks in the Megatron, although it was tested in 9 peaks also, but possibly the results are best in the bench testing on the Megatron 12 peak. In the body of the stent, there are 3 connectors with Megatron, whereas there are 2 connectors in the Synergy stent, and the strut thickness has also been increased to provide a better radial strength. So the same strength, same stent which we use 3.5 millimeter Megatron can be expanded up to diameter of 6 millimeter. So therefore, there is no doubt that Megatron is a large purpose-built stent for large proximal vessels, particularly for bifurcation. And one can say it is the best in class with unique features of unmatched overexpansion, high radial strength, uniform lesion scaffolding, and maximum visibility. Now, if you look at the features of this Megatron and you compare it with other stents like Resolute and Giants, it has the best axial and radial strength, including for those fibrotic lesions. The stent can be expanded to a wider diameter. A 3.5 millimeter stent can be expanded up to a diameter of 6 millimeter to accommodate, to avoid any mismatch in the larger vessel. And it provides a uniform scaffolding when it is expanded to a very large size of diameter, and it's nicely visible on fluoroscopy. This stent Megatron has the lowest amount of recoil, and this is possibly because the peaks has a wider angle as compared to the narrower angle with the other stents, and once the stent is expanded onto this maximum diameter, the acute lumen loss is only 2%, whereas it is bigger lumen loss with other similar kind of stents. It has also been shown in a computational stent model, and it was experimentally tested and compared with the others, Synergy stents, Synergy and Megatron 9 and 10 peaks, again with the Megatron 12 peaks, and it was found that the Megatron 12 peak stent has significantly better scaffolding as seen by the cell diameter, which is the lowest with the Megatron 12 peak stent as compared to Megatron 9 and 10 and as compared to Synergy. Similarly, the same model has also shown that the Megatron 12 has decreased significantly. The vessel prolapse has been shown to decrease significantly with the increasing number of peaks. And as you can see in this bar diagram, that the prolapse is the lowest with the Megatron 12 as compared to other. Now, when it was also shown in the bench testing that when you expand these stents, or any of these stents, whether it is the Element, Zions or Texas, etc., it has been shown that when you overexpand these stents, let us see that in the bench testing, 6 millimeter balloon was put in all these stents and overexpanded. It led to a distortion of the struts, and when there is a distortion of the struts, there is a larger cell opening, larger gaps in the stent, and this can lead to several problems in the form of plaque prolapse, reduced drug delivery, and high incidence of restenosis. So therefore, it is not advisable to expand it to the specified, expand it beyond the specified diameter of the stent. Yeah. So when we look at the initial experience of using the Megatron, it is a very small experience in 98 patients, which appeared in the Journal of Invasive Cardiology about 3 years ago. They had only 98 patients, and they found that the minimal stent area, when they compared with the Noble and Excel trials, it is not a head-to-head comparison, but when they compared the IVUS measurements in the Noble and Excel trials, they found that the minimal stent area in these trials was almost as much as with the Megatron, or in other words, the Megatron could achieve as much minimal stent area as with the in the LAD and LCX ostium. But when you look at the left main, the minimal stent area obtained with Megatron was significantly higher as compared to the Noble and Excel trials. So it showed that there is a superior capability of Megatron to achieve higher minimal stent area even with a 3.5 millimeter stent. Then there is the registry with the Megatron, which included 575 patients. The left main stenting was done in 55%, true bifurcation 50% of these cases, and follow-up was very only for 1 year. And they found that the TLF at 30 days was 4.5% and 8.6% at 1 year. You can skip this. Now, let me show you a case, an interesting case of Megatron, which was one of our first few cases. This is a 68 years gentleman who had no risk factors. He presented to us with ACS, recent oscent angina of only about few days. ECG showed a very shallow T-wave inversion in V4 to V6, and echo was normal. And this was the angiogram. This is the left coronary angiogram, which we could, I'll just take another 2 minutes, please. This was the left coronary angiogram, which showed that there is a very large size left main which divides into two major branches, the LAD which is much smaller in diameter, or at least on the angiogram. The circumflex has got again a much smaller diameter but a tight stenosis, and there is a third branch which is coming very early, the OM branch coming from the LCX. So basically you can say that it's almost like a trifurcation stenosis. Now this is the right coronary angiogram in this patient, and right coronary artery is equally bad. So he was advised bypass graft surgery, but at no point he was ready to listen, and including his family tried to convince him for bypass graft surgery, but he refused. So we went ahead and did the left main trifurcation stenting and wired all the three major branches, LAD, ramus, which was of course a OM or a ramus, and then LCX. And this was the pull back from the LAD. You can see here that the LAD diameter was almost about 3 millimeter or 3.25 millimeters. This is the left main. Yeah, the left main was much. This is the LAD about 2.5, and this is the left main which was almost about 3. So there is some amount of mismatch here. Now, when we went ahead and did the procedure, we did first the cutting balloon of all the three major branches, and following the cutting balloon dilatation, we used a bifurcation stenting which involved the LCX and the OM branch or the ramus branch using a mini crush technique. So these are the steps of the mini crush technique, kissing balloon dilatation, and after that you can see that there is a wide discrepancy in the diameter of the left main and the LAD. So we thought we would put a Megatron here, and so we put a 3.5 mm 32 Megatron, which was put from the mid LAD backward up to the ostium of the left main using a DK crush technique, and then the report was done. I am missing some of the steps here. The report was done using a 5 mm balloon, and this was the final IVUS pictures. You can see here that the minimal stent area on the proximal LAD was almost 10, and on the left main was 16 millimeters. And this was the final angiographic result showing a trifurcation stenting with the OM LCX bifurcations using mini crush and LAD LCX using DK crush. So friends, I conclude by saying that during left main bifurcation stenting, mismatch in sizes of the main vessel and the main branch is not too uncommon. Conventional DES from main vessel to main branch is often results in malapposition stent in the main vessel, and Megatron is a purpose-built stent for such large vessels, and personal experience has shown that excellent expansion and apposition of this DES in left main bifurcation stenting. Thank you.